Okay, now we're moving on to the next presenter. Conal Austin, an esteemed cardiac surgeon from Great Britain, will talk to us about a relatively new procedure of an old concept, the PEARS procedure, especially in the context of the Ross procedure, in order to eliminate the subsequent dilatation of the Ross autograft. Greetings to Great Britain and Conal.
Yeah. Can you hear me okay?
Yep. Yes.
Yes. Okay. Kalispera. And thank you very much indeed for the organisers to invite me to give you a progress update with our novel concept of Ross PEARS. But like many things, there's nothing new under the sun. All right, okay. So there's general agreement that the Ross operation is the aortic valve replacement of choice in children and young adults. However, not all Ross operations are created equally or technically the same. There are two broad types of Ross operation: the inclusion Ross, where the autograft is unfolded inside the aorta, and the free root Ross operation. Inclusion Ross operations probably give better freedom from autograft dilatation and valve insufficiency. When you look at the number of Ross operations done around the world, 90% of the Ross operations are performed as free root Ross techniques. The reason for that is that it's a quicker operation, it's much less complex than the inclusion techniques, which can be geometrically quite challenging when you're dealing with aortic root disease or bicuspid non-commissural problems with the bicuspid aortic valve. In free root Ross, after about 10 years, there's usually a 15 to 20% degree of aortic dilatation and aortic valve insufficiency, and it's difficult to predict which patients will dilate. So this is the reason why some surgeons have been adopting prosthetic support for the autograft in free root Ross. Traditionally, it's used as a Dacron cylindrical support. However, Dacron is stiff, it's non-porous, and it can lead to clot formation between the autograft and the supporting conduit. The Dacron Valsalva graft has also been deployed, which looks more geometrically appealing, but the autograft has to be pre-sutured into the graft, and this increases cross-clamp time and complexity of the operation. Over the past 9 years, I've been developing increased extensive experience with PEARS, personalized external aortic root support for connective tissue aortopathies, and I've introduced this technique into the adult congenital population. This is what we're trying to prevent. This is a child with free root Ross dilatation who had a previous Conal Ross only 3 years earlier. These are examples of the support with Dacron grafts. On the left-hand side, we can see a Gore-Tex being used to support the autograft or Dacron. But these jackets are cylinders and they don't look quite like all the numbers of aortas that I've operated on. This is a small collection of the number of PEARS procedures that I've performed. So what's the significant difference between the textile technology? The PEARS prosthesis is made from the same material as the Dacron. It's a multi-filament of polyethylene, but rather than being woven, it's knitted, which gives it a low stiffness, a high porosity, it's soft and compliant, and in animal studies where you wrap the aorta, it becomes integrated to the adventitia of the aorta, whereas if you wrap Dacron around the aorta, there's a space between the aorta and the Dacron graft. This is what we're trying to achieve, and this is the first patient to receive a PEARS for Marfan's disease some 16 years later, showing no change in aortic root dimension or change in aortic valve function. This is a schematic diagram to show on the right-hand side the free root Ross, and then the PEARS supported Ross. And importantly, the PEARS supported Ross carries the graft all the way up to the brachiocephalic trunk. For those patients who have got bicuspid aortic valve disease, they can go on to develop aortopathies beyond the sinotubular junction. In London, over the past 6 years, I've performed 24 cases at St Thomas's Hospital. I've also helped set up the programs at the Brompton, Amsterdam, and the Freeman Hospital, where a further 13 cases have been performed. So what have we learned? What have we learned by this evolving project? Well, the first patient I did was in November 2015. I did an inclusion Ross, and I supported the Ross with a PEARS modelled on the aortic dimensions. Then I realized that this probably wasn't so clever, and I thought that it would be an easier operation to do a free root Ross operation. So for the next 3 cases, I did free root Rosses, but I continued to measure the pairs based on the aortic dimensions because that's what we were doing with the Marfan's patients, and that's what we were familiar with. I then changed to do the pairs manufacture from the size of the pulmonary artery, from the CT pulmonary phase of the pulmonary angiogram. And also I found that some of the grafts were small, so I upsized them by 20%, and I call these 120% grafts. But even in these patients, the posterior sinus was very poorly formed, and I think it's due to compression on the left main stem. Yet when you explant the autograft and fill it with saline, the autograft fills a normal trilobular configuration. Now what we do is we advocate an upsize of the sinuses of the pulmonary artery to 115%, and we generate a new posterior sinus based on the size of the two anterior sinuses to give you that trilobular experience. These are some of the earlier pairs, and you can see this indentation at the back where the posterior sinus of Valsalva just is not properly performed. This is an example of a Ross pairs prosthesis still on its acrylic former. This is our evolution of the previous Ross pairs prosthesis from our earlier experience. There are three components. The first component is the annulus, and this is a double-folded layer of polyethylene, which gives it great strength. The second component is the sinuses of Valsalva, and this size of the graft can be upsized from 5 to 15% of the true size of the main pulmonary artery. The third component is the upstand from the sinotubular junction to the brachiocephalic trunk, and this can be specified between 3 to 4 centimeters, depending on whether a reduction aortoplasty is required. The sinuses of Valsalva are interesting. There's a drilled hole which I've marked with these two black dots, which show the anterior sinus of Valsalva towards the aorta. The second sinus of Valsalva anteriorly is towards the left atrial appendage. And the third sinus is now computer generated and printed on a CAD model, which equates to the size of the two anterior sinuses to give a perfect trilobular symmetrical pulmonary artery autograft support. We can see quite clearly the nice sinus of Valsalva, the commissure, and a further sinus of Valsalva. There is a longitudinal axial seam which is held together by this silt releasing suture, and when this is pulled, this releases the graft from the acrylic former. So as you can see in that short video, the new prosthesis is actually built of three components: the annulus, the sinus of Valsalva, and the upstand. The annulus can be specified depending on whether or not you plan to do a Conal procedure. And if the annulus is quite large, it can be set at 35 millimeters. I've just found that the sinuses should be upsized by between 5 and 15%. And I think that's because the CT scan gives you the impression of the blood inside the lumen of the pulmonary artery, whereas I have to deal with the thickness of the wall of the main pulmonary artery plus any adventitial fat. The upstand can be used to support the ascending aorta from the sinotubular junctions upwards, and I quite often do a reduction aortoplasty and contain that to make it the same size as the main pulmonary artery. This is a computer diagram just showing the three sinuses of Valsalva and copying the posterior sinus of the two anterior sinuses. So what's the current technique? I usually select the 115% prosthesis, I open the longitudinal axial seam, and I mark the well-defined commissures on the annular hem with a 5-0-proline suture. The pairs prosthesis is then implanted at the same time as implanting the muscular skirt of the autograft to the left ventricular outflow tract. Holes are then created anteriorly and posteriorly in the pairs prosthesis to bring through the right and left coronary arteries. If a distal aortic reduction plasty is to be performed, it should be done now, and then an end-to-end anastomosis of the autograft to the ascending aorta is performed. The RV to PA conduit homograft is implanted, bypass is then discontinued, and hemostasis is secured. When you're happy with hemostasis, the longitudinal axial seam of the pairs can then be reapproximated. Finally, we check with our cardiology colleagues to assess function of the aortic valve, coronary artery blood flow, and absence of regional wall motion abnormality. This video demonstrates the axial seam being opened up. I then take the graft off the former, and you can see the well-defined shape of the sinus of Valsalva. I'm now measuring this to take a 30 millimeter Hager dilator. And the same Hager dilator is used to get the size of the autograft. This was a patient who had a previous perimount prosthesis. And this is the finished product with the PEARS over the ascending aorta and autograft and the RV to PA conduit. To date, we've done 24 cases at St. Thomas's Hospital. Just over a third of them were reduced sternotomies, with some of them having had previous four sternotomies. 6 patients had pure aortic stenosis, 9 had pure aortic insufficiency, which can be controversial, and 5 had mixed aortic insufficiency, aortic stenosis. 4 had previous aortic valve prosthesis. In 10 of the 24, I performed a significant reduction ascending aortoplasty. 4 patients required a Conal Ross. The average age of the patient was 29, ranging from 16 to 49. The bypass time was 22 minutes, with some quite long procedures and the complex repeat operations. And the cross-clamp time was 153 minutes. We're following up the patients very carefully with an echo and an MRI at 12 months and every 2 years thereafter. Well, surgery is a great humbler, and my first patient actually came back for a reoperation. He was a 26-year-old patient who had rheumatic aortic valve disease. And I think the take-home message here is that rheumatic disease and Ross operations don't go because the pulmonary arteries just didn't tolerate systemic pressures. The second patient that required a reoperation was very distressing. He was a 21-year-old patient who had three previous operations, and his operation was complex in that I had difficulty with bleeding underneath the left coronary artery, which required an internal suture to close a small defect. Unfortunately, 6 months later, this internal suture split the left coronary leaflet, and I repaired the leaflet, but I wasn't confident of it holding, so he had a mechanical root replacement. Patient number 6, again, a complicated patient with previous aortic root replacement with a prosthesis called an Elan, which was 19 millimeters in size. She had endocarditis and she had a small aortic root. She needed a left coronary artery stent 36 hours after the operation. And I wonder, has that stent injured the valve? But she's now got moderate to severe AI, which she's tolerating, but will eventually come for a repeat procedure. No other patient has got greater than mild aortic valve insufficiency. And I've got a small period of time left. So I'm going to talk about, can you actually help those patients who have had a Ross operation and who've got a dilated free root Ross? Well, you can, because I've operated on 7 patients. 3 of them were teenagers who had a free root Ross who went on to dilate and develop aortic insufficiency, and 4 adults on an average of 10 years after the Ross operation. In some of these patients, you got increasing aortic valve insufficiency, and 2 of the patients had significant AI. I manufacture a PEARS prosthesis of about 80% of the size of the true aorta, and then apply that to the free root Ross. And 6 of the 7 patients were performed without the use of cardiopulmonary bypass. This demonstrates the dilated free root Ross with mild to moderate central regurgitation. And this is following the reduction pairs of the free root Ross. There's a diminution of the amount of AI, which can be seen on the longitudinal and cross-sectional view. So aortic root dilatation does lead to distraction of the leaflets and failure of coaptation, which can be improved. And we've seen this in other connective tissue aortopathies who have got dilated aortas with mild AI. This AI can be abolished by reduced size pairs. So in conclusion, this has been a very interesting project to design as bespoke external support for the Ross PEARS operation, using a 3D CAD model and the people at the Extent company who manufacture the PEARS for connective tissue disorders. As we've developed improved personalization of the Ross PEARS, the prosthesis is more easily implanted, is a perfect size. However, this is complex surgery and needs to be performed by surgeons with a high volume experience. Thank you very much.
Great presentation and outstanding results. We would like to congratulate you on taking this very technically demanding operation to the next level in order to avoid the autograft dilatation. I'm a little bit curious about the findings you had with the asymmetry of the pulmonary autograft and how you modified your PEARS sizing. Do you think this might be something that needs to be further studied, and how is that going to play into the future?
I think we were all very surprised by that, Fortis, to be quite honest with you. I thought that, like the aortic root and the extensive experience that we had with modelling PEARS for the aortic root and Marfan's, bicuspid aortic valves, Lloyd stents, ACTA2 mutations, etc., that the same thing would pass over from the modelling of the main pulmonary artery. But I was very disappointed with the PEARS that were being manufactured from the size of the CT scan of the pulmonary artery. And I think it is a fascinating, interesting area that somebody could study and work out. Why is it that whenever you take out a pulmonary valve, it has a beautiful trilobular state, yet when you make a model of that right ventricular outflow tract on a CAD computing process, it has an indentation or an absence of the posterior sinus? It's very interesting. I do agree.
Dr. Sparias is a commentator on this session, and he has a comment to make. Unfortunately, there's been an MI, just came into the hospital, so we'll give him the podium right now before he has to go. Kostas, please go ahead.
For the team, sorry I have to go for primary MI. Just a comment that I think it's relative to this discussion. Many years ago, I was proctoring a TAVI procedure somewhere in the US, Naperville, a suburb of Chicago, and the surgeon performing the TAVI was the primary operator was a surgeon, and he had developed, I forgot his name, he had developed a program for transapical stent, covered stent treatment of ascending aorta aneurysm. Do you have any comments to this treatment? Do you think it's something feasible? Because he was telling me that he had developed a good volume program, and he was proctoring also this procedure. I repeat, transapical treatment of ascending aortic aneurysm with a covered stent, self-expanding covered stent.
It's very interesting concept, but I can't really get my head around it at all. I mean, I've done over 170 PEARS, and one of the beauties of doing PEARS for aortopathies is that you can do them off cardiopulmonary bypass, and it's outside the bloodstream of the body, so it's around the adventitia of the aorta. But I think if you're doing something transapically, that implies that it's within the lumen of the aorta, or I just don't understand how that would not interfere with the function of the aortic valve.
Apparently, he was selecting cases that had dilatation only of the ascending aorta.
Ah, right. So it must be from the ascending aorta above the sinotubular junction, I suspect, and that's not dissimilar to many of the vascular procedures that are performed nowadays for internal lumen replacements of the descending thoracic aorta.
Thank you.
Thank you very much, Conal, once again.